tarde a todos, sejam muito bem-vindos a este webinar da SBNI sobre neurointensivismo, que é um tema muito complexo, né, para nós neuropediatras, e a gente sabe que a identificação precoce das condições neurológicas e o manejo pode melhorar as condições de recuperação do nosso paciente. And I will talk in English because we have with us, it's a great pleasure to have Dr. Anuj Jayakar from Miami with us. And I met Dr. Anuj in Bolivia some time ago, and I invited him to be with us. And he is a pediatric neurologist at the Nicholas Children's Hospital Brain Institute and the medical director of the Neurocritical Care Program for acute brain dysfunction. And I will repeat, but I said that neurointensivism is a very complex situation for our patients, and we know that the identification and the rapid identification and management of the neurological condition can significantly improve recovery chains. And it's a great pleasure to have you with us.
Oh, it's my pleasure. Thank you so much for the invitation. It was great seeing you in Bolivia, and look forward to continuing to meet you and hopefully some of your other colleagues in Brazil in the near future.
Yes.
Hi. Can you see my slides?
Yes. It's okay. You can start.
Perfect. So again, thank you very much for having me. I'm Anuj Jayakar. I'm the Director of Neurocritical Care at Nicholas Children's Hospital here in Miami, Florida. I specialize in neuro-ICU and epilepsy care. It's a field that has been growing very rapidly over the last 10 to 20 years, especially in pediatrics. And the main goal of neurocritical care, or NCC, is to improve patient outcomes following an acute brain injury or the progression or exacerbation of a chronic neurologic disease. We have many patients who come in with a brain injury. Unfortunately, there's not much we can do to prevent that initial injury sometimes, but there are things we can do to help prevent secondary brain injury that can occur hours or days after the initial event. This can occur due to a variety of different reasons, including hypoxia, ischemia, inflammation, and edema or swelling. The main way that we can help limit these secondary effects is through close monitoring in order to detect early brain injury and then to intervene before that injury becomes irreversible. There's a concept that we'll touch upon later on in the talk called multimodal monitoring, or MMM, which is where we use physiological measurements, including hemodynamic parameters and specific non-invasive and invasive neuromonitoring techniques in order to help intervene in a more timely manner. So for us as a neuro-ICU team, we're made up of different subspecialists, including myself as neurology, our intensive care specialists, neurosurgery, radiology, genetics, and many, many other team members that I'm sure I'm omitting in this slide. And the way we approach this is we work on 3 fronts to help improve patient outcomes. We want to, 1, focus on how we can improve our neuromonitoring. We want to, 2, focus on how we can make more rapid diagnoses. And 3, use those 2 aspects to advance our care and improve our treatments for our patients. So we'll start with neuromonitoring now. So initially, we were very limited. All we had was our physical exam. This was our first line in assessing the patient's clinical status and has largely been the neurologist's bread and butter for centuries. We can still utilize our physical exam to our benefit within the intensive care setting. It's good for evaluating the mental status of patients, brainstem reflexes, and to determine deterioration. It does, however, have many limitations. We're not always going to be at the bedside, so we can't do continuous exams on patients. We often have many, many patients, and we can't be everywhere all at once. It can lag, our physical exam can lag behind neuropathological and neurophysiologic deterioration. So for example, in the scenario where you have an intracranial hemorrhage that is worsening, or you have a patient who's in subclinical status, You may not necessarily see the changes in exam off the bat. Those may lag minutes, if not even hours after that change has already occurred. And finally, as you guys are probably well aware, many of the patients in the ICU are either in a comatose state, very sedated, or on pharmacologic paralysis, because that's what's required for their clinical situation. As such, our ability to examine these patients is very limited, and we can't do the full detailed head-to-toe neurologic exam like we would on many of our other patients in clinic. So what are some of our other monitoring options? I like to break it down to non-invasive and then invasive options. Our non-invasive options includes things like vital signs, EEG, NIRS, things that we frequently do, whereas our invasive ones are typically done in combination with our neurosurgery colleagues. So vital signs monitoring. This is kind of our simple, the easiest way to monitor patients. It's done in every ICU center kind of around the world. We will frequently watch the heart rates, the mean arterial pressure, pulse oximetry, and blood pressure. And all of these have a role in ICP and cerebral perfusion monitoring. We know that cerebral perfusion is the difference between our mean arterial pressures and our ICPs, and is one of the key kind of basically signs that we use that we keep an eye on in our kids with traumatic brain injury in the ICU. One other measure that is very important is temperature control. So it's very, very, very important to keep tight temperature control in our patients in the neuro-ICU setting. It's important to avoid hyperthermia. Persistent hyperthermia 24 hours post a cardiac arrest or traumatic brain injury has been associated with worse outcomes and higher mortality. We typically have very tight temperature regulation within our neuro-ICU. We do something called targeted temperature management of 36 to 37.5 in our patients, 30 degrees Celsius in our patients after cardiac arrest. In our neonates with concern for hypoxic ischemic encephalopathy, we frequently will do the neonatal hypothermia protocol where we'll keep their temperatures between 32 to 34 degrees. And there is now a kind of a large multi-center study going to look at the benefit of kind of various different temperatures post cardiac arrest to see if there's any kind of ideal range, because prior studies for this have been limited in that sense. So the role of EEG for us as neurologists and neurophysiologists, our EEG is kind of one of our favorite tools that we have. It can measure brain activity. It can be done at the bedside. It's got very good spatial and temporal resolution. And now we've been seeing that within the ICU side of things, there's a growing role for continuous EEG monitoring. We've seen that some studies have listed anywhere as many as 40% of children with critical illness who undergo continuous EEG monitoring will have electrographic seizures. About a third of those will meet criteria for status epilepticus, and about a third of them will have electrographic only seizures that we can only see on EEG. Obviously, continuous EEG has its challenges. The machines themselves are expensive and not as available as they should be. Technicians, especially in the United States, have been one of our main rate-limiting steps, in that it's been hard to get good and properly trained technicians to help set up the EEGs as well as to monitor them. And finally, you need trained epileptologists in order to interpret these EEGs, because EEG interpretation within the ICU and neonatal ICU can be extremely challenging due to some of the kind of the variations in kind of the brain's kind of brain hemodynamics. So when we think of the role of EEG in the ICU, there's a couple of key scenarios in where it's going to be very important. We want to use them when there's persistently abnormal mental status following generalized convulsive status epilepticus or clinically evident seizures. About a third of patients in this circumstance have ongoing electrographic seizures. So we always say that if there's no improvement in the mental status after 10 minutes following the last seizures, to consider EEG in these patients due to the risk of clinical seizures. For patients with supratentorial brain injury and altered mental status, those younger patients will be at higher risk. So for our patient population, we put most of them on EEG in order to monitor them a little bit closely. There are many additional indications within the ICU setting. This is kind of just a snapshot of some of the percentages. So as you can see here, even for things like intraparenchymal hemorrhages, the rates of seizures can be quite high, somewhere around 20% typically. But TBI, that number can go up to even 50% depending on the severity of TBI. So as you can see, within the ICU setting, there are many patients who could benefit from continuous EEG monitoring because the rates of subclinical seizures are so high. And these are just further examples of that. So how long do we do the EEG for? Well, ideally, you would want to connect these patients to EEG as soon as possible. So for your cases of cardiac arrest, for post TBI, for kids on ECMO, you would want to basically get them on as soon as you physically can. The length of EEG monitoring depends on the clinical scenario. There are studies that have shown that serial routine EEGs, where you do them every 12 to 24 hours, is still better than just doing one or no EEGs. For continuous EEG, the recommendation is to typically do it for 24 hours at least, but that depends on the scenario and kind of what kind of how the patient is doing. There has been more studies to see if we can use kind of initial EEG markers to try and see if we could cut down the amount of time that's needed on EEG. So we had done a study looking at our neonatal hypothermia patient population. Typically, because these patients are being cooled for 72 hours and then they're rewarmed, they had been monitored on EEG for 3 to 4 days. We did a study where we looked to see if their EEG background was normal or mildly encephalopathic in the first 24 hours, what the rates for seizures in that population later on were. And overall, we saw that basically the vast majority of patients who had normal or mild EEG backgrounds did not go on to have seizures later on in the cooling protocol. So most of these patients, we could stop the EEG after about 24 to 48 hours, as opposed to continuing it on for the full 72 to 96 hours. And then what can we do that goes beyond EEG? So now there's been a growing trend for both use of quantitative EEG and EEG connectivity within the ICU setting. So what is quantitative EEG? So quantitative EEG is a special software that makes a spectral analysis to display the different trends of like amplitude integrated EEG, rhythmicity, power, and asymmetry trends. So what it does is, you can see here on the right, it basically takes the EEG, breaks it down into separate waveforms, and then analyzes the strength of those waveforms to give basically different colors. And what we'll see on the display is in this bottom right corner over here, we see these kind of different charts. And what these charts indicate is in the kind of on the top, you see this bright red box. That indicates that there's a risk for seizure in that time. We see that in these kind of underneath with the darker blue lines, that's called a rhythmicity spectrogram, where the computer is telling us how rhythmic the waveforms are at any given moment, where if there's an increase in rhythmicity at a higher frequency, that raises concern for seizures. Below that, with this pink and white and green box, those graphs demonstrate kind of the frequency power, the frequency spectrogram. So when there's a higher frequency, we see kind of darker purple, red, and then white colors, where we could, again, where if you're seeing frequencies that are more powerful and more stronger, we could see that light up in that area. So these are ways that we can help gauge to see kind of what's going on from a global perspective within the brain. The nice thing about this is it helps us to review the EEG at a glance. We could change the time base of this. So rather than looking at a 10-second clip of EEG, I can look at a trend over hours, days, if I need to. It allows for a more rapid recognition of non-convulsive seizures. It's very good for helping with improving our timing of treatment, because if we can detect things faster, we can then treat more rapidly. It provides a quick overview of the seizure location, frequency, and duration. And it can reveal subtle changes in terms of background, state change, and things like that. So there's been more and more studies to see how we can use this more efficiently at the bedside. It is used in numerous ICUs across the United States. The challenge is there's a lack of training as a common barrier. So while many centers use it, how they use it is not consistent, and who uses it is not consistent. But there have been studies that show that we can train ICU providers, bedside nurses, techs, in order to help us with this detection process. So we've actually started a pediatric quantitative EEG task force that has many members from kind of all throughout North America. And I'm helping to lead our education portion of it to help standardize the education of quantitative EEG, and hopefully to kind of help expand the use for it throughout the country and internationally as well. So some other cool kind of uses that for quantitative EEG. Out of Washington University in St. Louis, they've been doing studies on a concept called macroperiodic oscillations, where rather than looking at a 30-minute window, they look at a 24-hour window or even bigger, and they look to see kind of for these subtle kind of like basically flames in terms of the frequency. And what they've been doing is in their kids with traumatic brain injury, they'll monitor these. And if they see these subtle changes, but that aren't necessarily seizures, then they may actually treat and see if they can get these kind of very low amplitude variations to go away and see if that helps with better outcomes in these patients. Moving forward to EEG connectivity, this is basically a way to see how each of the individual EEG electrodes are talking with each other using various different kind of component analysis. So what they'll do is you'll look at the different waveforms, you'll analyze each component and see how they link up between two different parts of the brain. And there is some sense that you can use this analysis in order to, for example, this study was looking at whether you can successfully wean off sedation in patients with some kind of super refractory status epilepticus. And so these markers where you see a greater split between the red and blue lines, when you saw that split in those indicated a higher success rate in terms of being able to wean. So moving on to some of our other kind of neuromonitoring options. Near-infrared spectroscopy is a tool that's been around for a very long time. It's electrodes that can be placed on the scalp to measure the ratio of oxygenated and unoxygenated hemoglobin. Overall, what we've seen is that higher cerebral oximetry values during cardiopulmonary, during CPR and after cardiac arrest have been associated with better outcomes. There are limitations. We don't know if the oxygen changes are due to changes in metabolic demand, due to swelling on the scalp. So there may be things that may give us false positives and false negatives, but it is still a useful and easily accessible tool for monitoring patients. Transcranial Doppler is something that's been gaining more and more popularity, especially in those patients with either traumatic brain injury or subarachnoid hemorrhages. They can measure the mean blood flow velocity in all our major cerebral vessels. It's been especially useful in cases where we're concerned for the potential for vasospasm. And what that means is when after subarachnoid hemorrhages or in cases of trauma, your blood vessels may progressively narrow, leading to secondary injury. So you could track the velocities within the vessels in order to gauge whether that may be happening or not. So when you see your middle cerebral artery with flow velocities of greater than 200, there has a positive predictive value of 87% for vasospasm. And then there's also a concept of the Lindegaard ratio, where you do the velocities within your MCA and your ipsilateral extracranial carotid. And basically, if you see that there's a significant kind of flow increase in velocity in your MCA versus your carotid, so your ratio greater than 3, that's a higher risk for vasospasm versus a lower one could be just hyperemia, where you're just getting increased flow to the head. So we can use these numbers to help us gauge our risk for vasospasm. And this is, again, a good, easy bedside monitoring tool to help us in the ICU. So intracranial pressure monitoring is typically kind of where we work most closely with our neurosurgeons. The goal is always to keep your pressures less than 20 mmHg. Ideal cerebral perfusion is going to be between 45 to 60. There's a variety of different ways to measure these. We can do indirect measures in babies, looking at the fundamental sutures, measuring head circumference, in bigger kids with optic nerve sheath diameter or with imaging. But overall, we frequently will need, in bigger kids especially, need more invasive monitors in order to help with that. The two ways that we frequently will do this will be through an EVD, or basically an external ventricular drain. This is where the surgeons will insert a drain through the non-dominant side into a burr hole. This is good because you can actively drain fluid out of the brain to help reduce pressure while at the same time monitoring pressure. There is a higher rate of complications due to kind of positioning that is a little bit more invasive, and there's a little bit of a higher infection rate. There are now fiber optic sensors that the neurosurgeons can place in and leave in place for 7 days or longer. They allow for continuous monitoring, whereas the EVDs do not, but they don't allow you to drain the fluid at the same time. So some pros and cons depending on your scenario. We've started to do a little bit more cerebral oxygenation monitoring. So the concept of cerebral oxygenation, or PBTO2, measures the partial pressure of oxygen in the brain tissue. Not surprising, low PbTO2 is associated with higher morbidity and mortality, whereas greater PbTO2 is greater than 30 result in better outcomes. So what this is, it's the probe that you could place in the brain parenchyma, and it's a good measure for ischemia and hyperemia. It doesn't reflect global oxygen intake. So for example, if you put it in the right frontal lobe, it doesn't tell you what's happening everywhere, but it is at least a little bit of a better measure of that. And then finally, cerebral microdialysis is another up-and-coming monitoring tool. It is an invasive technique where basically a small catheter is inserted into the extraparenchymal space. And what this does is the catheter has a double lumen probe that has a dialysis membrane. So what you can do is you can send dialysate in that then equilibrates with the CSF. So that way you can get kind of live markers of glucose, lactate, pyruvate, glycerol, and glutamate. So if you're worried about ischemia, an elevated lactate to pyruvate ratio can be a marker for that. Glutamate, which is a marker of excitotoxicity, also is associated with hypoxia and ischemia. So these are some newer kind of technologies that we're kind of analyzing to see how well we can use these in pediatrics. So now shifting from monitoring more to rapid diagnosis. So we know that for many conditions, time is brain. There are many neurologic emergencies that are very time sensitive. For example, hemorrhagic strokes require urgent neurosurgical intervention occasionally. Acute ischemic strokes, or especially arterial ones, we have many time sensitive interventions, whether that's TPA within a 4.5-hour window, or now more and more, we're looking at mechanical thrombectomies or intra-arterial TPA, where we could potentially intervene as close as 12 hours out. For status epilepticus, we know that the earlier we intervene, the better our outcomes are, and the more likely it is we are to be successful in our treatment. Failure of diagnosis can result in delayed care, prolonged hospital course, and worse patient outcomes. So this is kind of a study that was looking at the early importance of early detection in status epilepticus. We know, again, not surprisingly, treatment delays can lead to longer seizure duration. So when kids received the initial benzo treatment after 10 minutes, their had a higher odds ratio for mortality, for requiring continuous anesthetic infusion, and for longer convulsive seizure duration. So not surprisingly, these kids had worse overall outcomes. So what are some other ways we can improve our diagnostic capabilities? There are now guidelines for when we should be having for conditions like inflammatory and infectious etiologies. There are now guidelines for when we should think of a presumed versus possible autoimmune encephalitis. These are kids that should get tapped, should have autoimmune encephalitis panels sent, and then ideally get treated with early immunomodulation, whether that be steroids, IVIG, or potentially even plasma exchange or other immunomodulatory treatments. In patients where we're concerned for fires or fever-induced refractory epilepsy syndrome, there are immunomodulatory drugs such as anakinra that have been shown to have better early efficacy, as well as things like the ketogenic diet or plasma exchange. And then finally, there are many now genetic options that we can do to help us get genetic testing options that we can use in order to help get a rapid diagnosis. So we've been using rapid and ultra rapid whole genome studies. This is a paper that we hope will be coming out soon, where we did this in kind of 33 patients and had with a presumed neurologic diagnosis. And we had a positive pathogenic variant in about 60% of those patients, so a pretty high number. So overall, we've been doing these kind of tests more and more, and we've been seeing that it's helped us, one, get a diagnosis, and two, helped us with kind of managing our outcomes in these patients. Now shifting to advanced care and treatment. So our neurocritical care team helps to optimize treatment in a variety of different ways. We act as both the bedside. We focus on bedside and unit-wide improvements. As neurologists, we are just one member of a large intensive care team, but we act as a primary kind of basically communication lead to help with these neurologic emergencies. So by being there on a regular basis, we've been able to build up good relationships with all the members of the intensive care team. We help improve communication between the teams to help optimize our treatment and make sure that things go efficiently. There's been a greater growth in protocol development for whether it's for status epilepticus, code strokes. There was a study out of the Hospital for Sick Kids in Toronto where they showed that when they instituted a code stroke protocol, it reduced their average time to diagnosis, and they were able to have increased use of MRI. Furthermore, we've been able to help through this growth of neurocritical care. There's greater focus on multi-center research, quality improvement, and seeing what we can do to help reduce the length of ICU stay and hospitalizations. So it's great that we're able to integrate within the ICU to help avoid delays in care and avoid practice variability. By standardizing things, we're able to help make sure that the same level of care is delivered on a regular basis. And we've seen more and more that by being on the ground, we're able to help bring in our therapists earlier to help improve outcomes, whether it's physical therapy, occupational, or speech and language therapies. So now we'll kind of shift gears to some specific treatments within the ICU. So we have kind of shifted our focus. Status epilepticus has been something we've been focusing on for a very long time. We have largely adopted our hospital protocols based off the American Epilepsy Society recommendations that were done about 5 years ago at this point, where basically the main goal is to still give the first dose benzodiazepine after a patient has been seizing for for more than 3 to 5 minutes. If there is no IV, we've shifted towards intranasal, intramuscular, or rectal options. And you can see the dosing recommendations for the benzodiazepines there. More and more, though, if the initial benzodiazepine has not been working, we've been moving towards a higher dose of a second-line anti-seizure medicine, with the most common ones being IV fosphenytoin, IV valproic acid, or IV Keppra. There's the main thing I always harp on, and I recommend for you, is to look at the dosing. So for Keppra, for active status epilepticus, we'll use a dose of 60 milligrams per kilogram or 4,500 milligrams per dose. If it's for Depakote, we will use a dose of 40 milligrams per kilogram or 3,000 milligrams as a max dose. And for fosphenytoin, it's 20 mg per kg or 1,500 milligrams as the max dose. So a little bit higher from a dosing perspective than what was used in the past. And this was based off the ESET trial that came out a few years ago, where we were trying to figure out which anti-epileptic to choose. Overall, they compared valproate, fosphenytoin, and Keppra, and saw that they were roughly equal amongst the three of them. There was no significant difference in seizure cessation between the three. There were a little bit of higher rates of hypotension and intubation in patients requiring fosphenytoin, as well as a higher mortality rates in patients requiring fosphenytoin, but nonetheless not clinically significant or not statistically significant. And finally, in patients who are in super refractory status epilepticus, there is now really no good recommendation in terms of which medication to do. This is a list of all the potential options that are available. We frequently will use midazolam or pentobarbital, and these are the doses that you can see there, typically by bolusing them with an initial load and then starting them at a drip, with a goal that then if we need to keep pushing up towards burst suppression, we will keep bolusing and increasing the drip as needed. More and more, there has been a push to do ketamine more, and there's now a multi-center study looking at ketamine for super refractory status and even for status epilepticus management. Once we get past that, we look for other potential therapy options. If we are having patients with super refractory status, things that we'll look at beyond the usual anti-seizure medicines or sedatives would be things like immunotherapy. So especially if we're suspecting an autoimmune or inflammatory etiology, there's no really good evidence to support when or which type of immunotherapy to give. But oftentimes, in addition to the anti-seizure medicines, I will give patients either a course of high-dose methylprednisolone with the corticosteroids, so 30 milligrams per kilogram per day or 1 gram. Or I'll try, if I'm concerned for infection, I might try IVIG instead with 2 grams per kilo split over 2 to 4 days. And finally, if we're concerned for fever-induced refractory epilepsy syndrome, I'll often do anakinra earlier on in their ICU course. There's been many studies looking at the ketogenic diet in patients with refractory status and super refractory status epilepticus. Overall, it's been shown to be effective. The main issue is we typically start this when the kids have been already in the ICU in sedative drips for almost 2 weeks. It does take some time to achieve ketosis, but many patients, so about 70 to 90%, were able to have seizure resolution and wean off anesthetics. So it is something that we recommend and that we use quite frequently. Epilepsy surgery is something that is, I think, still underutilized in the ICU setting. This is a study from our institution back in 2013, where we looked at kind of 15 patients with super refractory status epilepticus who underwent epilepsy surgery. They did an epilepsy surgery evaluation using ictal SPECT and PET. And overall, all the patients who underwent surgery were able to be weaned off sedation, transferred out of the ICU eventually, and there was no operative mortality. So in the right scenario, these are kids that we should be moving towards surgery probably earlier than we historically have been. Some alternative therapies. So we're always looking for different things that we can use to help stop seizures and help prevent refractory status epilepticus. So more and more we're using lacosamide as and it's an additional IV option. It looks to be as efficient and as efficacious as some of our other anti-seizure medicines. Perampanel or Fycompa is something that has been looked at as because of its different mechanism of action. Briviact or brivaracetam is a novel version of Keppra that we've been using just because it has fewer side effects and conceptually may pass the blood-brain barrier a little bit faster. Other options are neurosteroids such as allopregnanolone or ganaxolone. Unfortunately, these haven't shown clear benefits in phase 3 trials, but it's something that are still being looked at. Therapeutic hypothermia has been something that's been looked at, but not well studied. And then finally, neurostimulation is something that's gaining more and more traction. It has been transmagnetic stimulation, or TMS, has been shown to help in about 70% of patients with focal motor status epilepticus. Vagal nerve stimulation has been helpful, and electroconvulsive therapy has been shown to be helpful in individualized case reports. So shifting from seizures to stroke. So we're actually in the process of redoing our stroke protocol here at Nicholas Children's. And as such, this is something that we've been talking about quite a bit. The main goal is, one, how do we stabilize these patients and do neuroprotective measures for all patients we are concerned of for acute stroke. The main goal is to do close blood pressure management, avoid hypotension, and keep their blood pressures in the 50th and 95th percentile. You want to maintain normoglycemia, avoid hypo or hyperglycemia, maintain normal temperatures, monitor hydration, and treat seizures. This should be for any kid, whether they really receive kind of thrombolysis or not. And when we think of thrombolysis, that's primarily going to be TPA, where basically the recommendations for TPA are any child greater than 2 years of age with a radiologically confirmed stroke and no hemorrhage, who has a stroke scale greater than 4 and less than 24, but within 4.5 hours since symptom onset. It's been tough to push that number further just because it's been hard to do kind of large centered studies to look at this. The TIP study was done a few years ago, but ultimately was failed and closed due to difficulty with enrollment. Now we're looking more and more at endovascular therapies. So whether that's intraarterial thrombolysis with TPA or mechanical thrombectomies where we use a catheter to physically remove the clots. This has been shown to result in significantly better outcomes in adults, where now the recommendation in adults is for intervention within 24 hours from symptom onset. There aren't very good studies in pediatrics, but the overall suggestion is that for any patient less than 18 years of age with an acute ischemic stroke, with a large vessel occlusion and presenting within 6 hours, these would be potential candidates for this. Regardless, for all patients where we're concerned for an acute ischemic stroke, if they're not getting TPA or a candidate for intervention, these are all patients that we will start on some form of antiplatelet or anticoagulation. Overall, the risk for bleeding in pediatrics is very low. I'll either start patients on an aspirin or a heparin drip. It just depends on the clinical scenario. Long-term anticoagulation is indicated in children with a cardiac embolic source, a dissection, or a thrombophilia that's detected from the hematologic workup. Anticoagulation should not be started within 24 hours if TPA is administered. But again, the vast majority of patients with arterial ischemic strokes will be not TPA candidates, so most of them will be able to start on one of these within the time they get admitted to the hospital. And finally, with neurosurgical intervention, most commonly, neurosurgery will not need to be involved with stroke patients. But there are scenarios where they may be required due to concern for increased ICP. Most of those will be in the setting of a large middle cerebral artery infarct involving more than 2/3 of a vascular territory with midline shift and with other kind of hemodynamic markers that are abnormal or with a stroke scale that's very high. Typically, we would want to do the decompressive craniectomy early, but if they've received TPA, that needs to wait for at least 24 hours after TPA administration. So some kind of additional topics in kind of neuro-ICU care. So this is actually a cardiac arrest protocol that we've done for post-cardiac arrest care. So these are for patients who've undergone either out-of-hospital cardiac arrest or for in-hospital cardiac arrest, 3 to 5 minutes. And what we've tried to do is kind of list out kind of our early phase neuroprotective measures, including telemetry, temperature management with lab tests, EEG monitoring, and imaging, as you can see here. And then kind of shift to more of our recovery phase within kind of 2 to 3 days, where we kind of focus on getting therapy involved, dealing with the kind of autonomic symptoms or other kind of complications of injury, and using this as a framework to help move our level of care forward and make sure we're doing things in a timely manner. And then we'll close with traumatic brain injury and just general brain injury management. There's the acute management window where you want to avoid extremes. So you want to avoid hypo or hypertension. You want to maintain normal glycemia. Like I mentioned, we keep very tight temperature control. Depending on the etiology, it can be anywhere from 32 to 36, 37.5 degrees. We do want to treat seizures. Those patients at higher risk will be younger age patients, less than 2 years of age. Those who have a significant severity of injury, those patients with subdural hemorrhages, and those patients who have traumatic injury as opposed to other forms of brain injury. There is a consideration for seizure prophylaxis with Keppra or phosphodiesterone. We typically will do it if the patients will have an intraparenchymal hemorrhage or if they have subdural hemorrhages causing midline shift. And finally, you want to do close ICP monitoring and manage ICP as you need. But also, these patients are all frequently in the ICU for a long period of time. So we also have to learn to deal with to manage them from a subacute phase as well. So whether that is with their dysautonomia, or the neurostorming, as we mentioned, where they'll have spikes in their blood pressure, their heart rate, they'll stiffen, they have temperature dysregulation. Often things that we'll do to help with that is we'll do environmental regulation. We'll try and minimize the amount of stimulation that they're getting if we can, regulate their day-night by opening the windows, doing things like that, just to kind of help them regulate as much as possible. But oftentimes we may need pharmacologic agents to help with that, whether that's benzodiazepines such as diazepam, beta blockers such as propranolol, central dopamine agonists like bromocriptine, or other agents like gabapentin, clonidine, or chlorpromazine. We have a variety of different options, and I will treat based off the symptoms that the patients are having. Furthermore, it's often these patients with brain injury will go on to develop spasticity and tone abnormalities. These patients' early mobilization has been shown to result in improved outcome. So frequently we'll have our physical therapists work with the patients as soon as they're physically stable. But then often we'll use medications such as baclofen, diazepam, gabapentin, and Botox in order to help with the mobility in these patients as much as we can. So just to conclude, overall, optimal neurocritical care requires a multidisciplinary team approach. It is helpful to have a dedicated neurocritical care specialist and team to really kind of be the main face within the intensive care setting. The goal is to utilize all available resources to improve diagnosis and treatment. So if you have limited EEG, use what you have. If you have kind of all the tools known to man, use them. Try and create protocols to improve your monitoring capabilities as best as possible. Developing pathways and protocols allows for standardization amongst providers. So keeping status epilepticus, code stroke protocols, traumatic brain injury protocols allows there to be less variability and allows for the hospital to maintain kind of evidence-based kind of management in these patients. And then it's important to track outcome measures, including ICU length of stays, mortality, morbidity, and and see how we can better optimize our resources. So I know I covered a lot in a short period of time. Like I mentioned, this is a big our neuro ICU team is huge. We require multiple different subspecialists to function on a daily basis. But it's something that we love and we hope will continue to grow in the future. So thank you again for having me today, and I look forward to your questions. Thank you.
Thank you, Anuj. It's great to have a great revision of everything on ICU. And there's a lot of things. Now we don't have all this monitoring that you have, but we are trying to improve. And maybe one day we have to. Great. Thank you.
No, and I agree. Even for us, we don't have all of these things. We try and grow little by little and do the best that we can. So I think the goal is just to try and take advantage of whatever resources you have and use them as efficiently as you can.
Yes, I think the most important maybe is the EEG.
I agree.
As the first, because I think it's easier for us, but I think with the time we can improve.
Yeah.
To be better for this patient. May I see if I have some questions? Oh, I have no questions. I think because it's in the afternoon, we don't have a lot of here with us, but we will put this class in our site, and I think after a lot of people will see.
Fantastic. And if any questions come up, I'm always available, so I'm happy to help discuss either in person and by phone or by email. So it's no problem at all.
And maybe the next year we have you here in person with us.
It would be my pleasure.
Next year, and we can do a great discussion about this.
That would be my pleasure. I would look forward to that.
Okay. Thank you a lot.
Thank you. Good seeing you again.
Thank you.
Okay. Take care.
Take care.